Dr. Payne Show, 1-855-55 Lou, DRLOU is the number. It's info@paincarecanada.com. Back for another show. We have a full roster this morning.
We do.
What's going on, pal?
Not too much. How are you?
I'm good. How
was the week?
It was excellent. The weekend is here, so all things are good. But Like I said, we have guests in here.
Yes, we do. Today we have two special guests. We have Dr. Manoj Bhargava, an orthopedic surgeon from Etobicoke General Hospital. We also have Dr. Rob Gordon, who's also an orthopedic surgeon at Etobicoke General Hospital. They both, Rob specializes in knees, and Manoj also specializes in shoulders. Is that right, Manoj?
That's right.
Yeah. So we wanted to bring them on again today just to highlight the importance of the Knee Clinic initiative that we've been doing, where you can give us a call directly or email us at info@paincarecanada.com, see if you qualify for the inclusion criteria and get seen by a specialist right away. And so we wanted to bring on these two experts today to essentially highlight how important it is to take advantage of a program like this for so many different reasons. And prior to starting the show, we were just talking about how when people don't get seen soon enough with a knee injury, it actually can reduce or hinder their outcomes later on and how they can eventually get better. And Dr. Bhargava had some cases that he was thinking about that kind of highlight that importance, why it's so important to be seen early, and when you're seen later on, how that potentially can reduce your overall outcome and prognosis.
So recently, actually just yesterday, I saw a patient, that 22-year-old man who had a soccer injury about 6 months ago, and almost immediately noted that he couldn't straighten out his knee.
Right.
Now, perhaps like a lot of 22-year-olds, he kind of ignored it, had some swelling initially. Things got better fairly quickly, and he didn't really see anybody about it. And this guy has been walking around on a knee that won't go straight for about the last 6 months.
Right.
So that's something that in the knee world is sort of an urgency, maybe not an emergency, but certainly not something that should wait a long time. So this is what we call a locked knee. A knee that can't go straight after an injury is something that we need to treat fairly aggressively and fairly quickly.
Mm-hmm.
So certainly in this guy's case, because he hasn't been doing the right things and has not been walking properly, his muscles have atrophied. So first problem that we encounter is he needs to rebuild the muscle, which is going to delay his treatment even more.
Mm-hmm.
And then ultimately he'll need to have surgery for his locked knee.
Right. And then he'll likely have to do even more rehab after the surgery as well to get better.
Yeah, certainly the post-surgery rehabilitation is just as important.
And so this is probably more prevalent than a lot of people expect. I know from my practice and seeing all different types of pain conditions, people will tend to leave things because they think it'll just get better on their own. And you highlighted there that there's some things in the knee world that have a sense of urgency to them. Are there other things that you or Dr. Gordon could go through that would highlight what that urgency is? Like you mentioned, the locking. Is there something else that is a certain sign or symptom that a patient can observe in themselves that they should say, hey, this isn't something that I just will likely get better on its own?
Before we get into that, just one of the reasons why it's important to see these people with a locked knee early is because the reason for the knee not going straight is usually because something is jammed in the knee that's preventing it. So the delay in treatment there results in damage to the surface, the articular surface, and to, in this case, the meniscus itself, which really makes fixing it much more difficult than it would have been 6 months ago.
And that you mean from a surgical standpoint? Right.
It's like a stone in your shoe.
Mm-hmm.
You would never keep a stone in your shoe because it's rubbing, it's wearing out the bottom of your foot.
Point.
So having a meniscus or something else stuck in your knee is working exactly the same way, where it's rubbing and taking apart and roughening up the smooth surface, or what we call the articular surface of the knee.
What is the primary function of the meniscus, just for our listeners who don't really understand the structure of a knee?
I have no clue. It acts as a shock absorber.
Okay.
And just like in a car, so when your shocks go, it's really bad for the car and the rest of the car. Same thing with the knee. It acts as a shock absorber and protects the knee.
So outside of things like locking, which we've now talked about, what other things are potentially, red flags or maybe not necessarily a red flag, but something that a patient should be more aware of? I know in my practice, clicking, swelling, those types of things usually.
Swelling is very important. So anytime you have an acute injury, and acute means sudden, so something that occurred really quickly. So as a slip or as Manoj described in soccer, when you get hit from the side, or in football. So there's swelling. There's giving way. So you're walking, all of a sudden your knee buckles, so buckling or giving way, swelling, locking, which is critical, and a lot of pain. So those are all things that one would look for in an acute knee injury.
Right. A lot of patients that I've seen will often talk about, they will tend to confuse things like crepitus and clicking, and obviously clicking is probably more worrisome from a surgical perspective than just the crepitus that happens due to just degenerative changes. How can a patient know whether they're experiencing a true click versus crepitus, just because they're not experts on this?
So I think you got to break it down in terms of mechanical symptoms versus non-mechanical symptoms. So from a surgery standpoint, mechanical symptoms are really important. So clicking that's painful may be something that would be worrisome, whereas just general clicking in the knee usually is not so worrisome.
Not so worrisome.
Well, I want a definition of crepitus, other than sounding like a character from Lord of the Rings. I have to find out what that really means. The number 1-855-55-Dr. Lou, DRLU, or info@paincarecanada.com. The Dr. Payne Show continues. Global News Radio, 640 Toronto. 1-855-55-Dr. Lou, DRLOU, info@paincarecanada.com. Lots more of the Dr. Payne Show here. We're talking about knees and the clinic, right? This is new. We talked about it last weekend, but I want to break it down a little more.
Yeah, we're going to keep highlighting the knee clinic initiative and go on it. Now I'm laughing because I don't want to use my hands. Dr. Gordon was making fun of me for using my hands while I speak. But
on the radio.
On the radio.
Because we can all see.
But yeah, we just ended the last segment speaking about meniscal issues and the things that can happen in the knee. And we're going to go into a little bit how those things are potentially treated from a surgical standpoint. And we'll let Dr. Gordon and Dr. Brigava touch on that. And that will highlight, they'll also touch on why it's so very important to be seen early, which is the whole point of this clinic that we're doing, this initiative. Remember, just give me a call, 1-855-55-DRLOU. We'll have a quick conversation, see that if you qualify, and then you can get in to see a specialist right away. And there's not going to be that long wait of waiting to see your family doctor and then potentially waiting months and months to see a specialist. This is something that's going to get you in and get you where you need to be much, much quicker. So, gentlemen, the way we ended off again with the meniscus injuries, what are some of the surgical ways that those things would go about being treated?
So once we've seen a patient in the office, and again, I want to congratulate you on this initiative because it is getting patients in earlier. And when we get patients in earlier, it's better for them. They get back to work, back to their activities, and we're saving their knees.
Right.
And I think that's wonderful. So when you do come in, Dr. Brigava and I would assess a patient, see what their symptoms are, see what their function is, and assuming that they do have a meniscal tear, and 90% of the time, we can figure out whether a patient has a meniscal tear just by history and physical exams. So we ask you questions, ask you how it happened, and 90% of the time we can figure out what the diagnosis is. So you don't need MRIs, you don't need useless and costly ultrasounds. So it's very important, especially Manoj, who's gone to Harvard and Yale, can figure that out much easier than I can. So, but once you're in there and we figure it out, we would talk to you about the risk and benefits of surgery. We usually put 3 holes in a knee. It's called arthroscopy. So we're looking inside the knee with, some people call it a laser, but it's not. It's a camera. Okay. And we put equipment in and we try to fix the meniscus, repair it, which Manoj does a lot of, and it's great because it keeps the meniscus in your knee, which is really important. So you're fixing that shock absorber, keeping it there, making it functional again. Right. Sometimes you can't save the meniscus and you have to trim it out, and we always try to leave as much meniscus or cartilage, they're both synonymous, in the knee.
Right.
So I'll turn over to Manoj, and he can talk a little bit what happens when you try to repair it.
Yeah, so I mean, many years ago, the treatment for someone who would present with a meniscus tear would be to make a fairly big incision and to remove the meniscus, because surgeons at that time didn't really understand the function of the meniscus. As you discussed, the function of shock absorption wasn't really understood. And those patients did fine short term, but longer term, most of them developed at least X-ray arthritis on X-ray. So
can I interject for 1 second? Yeah. A cool anecdote for that. The only non-athlete in the Sports Illustrated top 100 important people of the century was Bob Jackson from Toronto, who brought arthroscopy to the world from Japan. So it's actually was invented and used a lot in Toronto by Dr. Bob Jackson. Sorry to interrupt.
Yeah. So initially, people were taking out the meniscus. So as Dr. Gordon mentioned, sometimes removing part of the meniscus is necessary. Preferably particularly in younger patients, what you'd like to do is save the meniscus.
Right.
And that may require, and not all menisci are savable, but the ones that are, particularly in young patients, certainly an attempt to repair it should be done.
Right.
The benefit is certainly that if it heals, and the chances of it healing in a young person are actually quite good, but if it heals, then the risk of arthritis goes way down.
Right.
In the future.
Right. If there's not enough to save, you have to remove most of it, if not all of it. Is there, as you say, a new shock absorber that could be put in there? A manufactured one, a plastic one or something?
Great question. You're going to win the Nobel Prize if you figure that out. Honestly, you will. Yeah. We've had so many things that have been invented, like fake cartilage, metal cartilage, artificial cartilage.
Well, cartilage from a dead person.
Yeah.
Right? So allograft.
So we do have...
is an option. The problem with allograft is that they fail.
Right.
So...
Right.
I mean, sometimes you have no choice in a 15, 16-year-old to, you can't save the meniscus. You're setting them up to do an allograft, but that also has its problems.
So something that I think that I heard you say, Dr. Brugava, that I think is really important to highlight, because in all the patients that I see, one of the things is people often, if they can, want to avoid surgery, not realizing that sometimes it's the only option that they have or the best option that they have. And there's always this thought that a surgeon will want to do more than they really have to. But like you said, if you can save a part of the meniscus or not be as invasive as possible, I'm sure that you and Dr. Gordon would opt for that. Like if you see a patient and they're not really an ideal candidate for surgery, you would make that recommendation and give them other options. And I think that's something that's important to distinguish for our average listener, because they think if they're going to a surgeon that all the surgeon wants to do is operate on them.
No, I mean, I don't think that's true. I mean, I think we're quite judicious about who really should have surgery, I think.
Right. Yeah.
And unfortunately, a lot of people will come in with knee pain that may or may not have a meniscus tear on MRI or other imaging,
right,
and they may not benefit from surgery.
You want to send me emails anytime, talk about this topic. If you have a question, no problem. info@paincarecanada.com. We'll put you in touch with Dr. Lou anytime. Otherwise, the phone number, 1-855-55-Dr. Lou, DRLOU. It's the Dr. Payne Show. Global News Radio, 640 Toronto. 1-855-55-Dr. Lou, DRLOU for contact, or info@paincarecanada.com.
Okay, so yeah, again, talking about specifically knee pain and issues. The last segment we touched upon a little bit with when people, I mean, the first point of contact is your family doctor. Everybody knows that. And, sometimes people will go to their family doctor. They'll see their family doctor for something like a knee issue. And the family doctor may say, okay, well, I'm going to refer you to a specialist. But people end up wanting, for whatever reason, the mentality is that the better the test, the more information that it can provide. But as Dr. Gordon was saying, that a trained specialist such as these two gentlemen here can hear what you have to tell them and then do a physical exam and, within 90% be somewhat certain about what the potential diagnosis is. And so I think a lot of the times people wait or are insisting on wanting to have those tests. Those tests cost a lot of money. They can take a lot of time, and they probably don't provide much more information to you guys. And if you guys think you need them, you can order them. Can you just touch upon that a little bit?
Yeah, I think those tests certainly delay the treatment and add a whole bunch of costs to the system that aren't necessary.
Right. When is it necessary to have an MRI or something like that? When should someone be going to that route?
Well, I think if the physician or the specialist is unsure what the diagnosis is, I think that's a very good reason to ask for an MRI. You have to understand it does sometimes take 3 to 6 months to get an MRI.
Yep.
So again, you're losing a productivity at work, with recreation, with your life, or whatever it is that you're doing to try to get back. So a specialist and a good family doctor will be able to diagnose that without those special tests.
Now, another thing that I've seen a lot in practice, and I see this a lot with the low back, and I think it's maybe similar, that sometimes some type of a healthcare professional will order an x-ray, you see some mild degenerative changes, and automatically it's assumed that it's that slight wear and tear that is the cause of the pain. And I know specifically for the low back that a lot of the times the correlation that the research gives us between what we see on imaging and what people actually experience is about 50-50. You can't always say that all the exact same patients that have degenerative changes always have pain, and some people have a lot of pain and not a lot of degenerative changes. Is that a similar situation to the knee?
Yeah, I mean, I think the one of the problems in the knee is that most of the time the pain is medial, which is the inside of the knee.
Right.
And the issue is meniscus tears are usually medial, always usually on the inside of the knee, and most arthritis is also on the inside of the knee.
Right.
So one of the biggest questions that we face is it the arthritis? And if they've had an MRI now, is it the arthritis or is it the meniscus tear in, say, somebody that's 50 plus?
Right.
So you have to, and it's important to make that distinction because the treatment is very different.
Mm-hmm.
So if the meniscus tear we think is causing the trouble, then you would be more likely to undergo an arthroscopy. On the other hand, if the arthritis is the issue, then you may be more likely to be treated conservatively with physiotherapy, possibly injections.
Right.
So sometimes the character of the pain may be useful. So often we'll ask the question of what's your pain like? So sharp pain may be more characteristic of meniscal pain, whereas an aching discomfort when you stand up, when you get up from a chair and start walking, that aching discomfort that you have, or just the ache in the knee, that more typically is arthritis. Now, not everything follows those rules,
right.
But that's sort of what we use.
But that's a guideline. Now, is it useful for anybody that has, and again, to touch upon the imaging aspect, is it useful for somebody who has a knee issue to always have an x-ray or always an ultrasound, not even focusing on a more expensive and more elaborate test like an MRI, but are those more simple tests that are more readily available potentially a good idea to have? Or same thing, it's still better to be seen by someone who knows what they're doing with the knee and can listen to what you have to say in the form of history and see you from a physical exam standpoint?
I think, again, emphasis on history and physical exam. If someone's a little bit older, middle age, older, sometimes an x-ray may help you to determine how bad the arthritis is, if there is arthritis. And one of the things is that when you do see the arthritis on an x-ray, and there's there's not a lot of space between the two bones, between the thigh bone and the shin bone, that sometimes an arthroscopy may not be beneficial. And as Manoj said, you may look at non-operative means to try to get people better.
What are some of those non-operative things that can be done?
There's rehab, whether it's physio, chiro, massage, osteopathy, exercise, strengthening. Then there's the other non-operative things like medication that might be able to help, but there are complications potentially with medicine. Sure. There's injections like PRP, which I think is effective in the literature.
Right.
Again, strengthening and exercise.
Yeah. And on that point, if anyone's ever interested in PRP, simply give me a call, and we can also help to coordinate that. It's something very interesting, and as Dr. Gordon said, it does have good outcomes for things like knee issues. I believe also some shoulder issues. Dr. Burgava?
Certain shoulder issues for sure.
Yeah. But again, the point being here that if you have knee pain, you're unsure of what's going on, you got to give us a call, try to figure this out. We can get you in to this knee clinic initiative, which will expedite your care. You're not wasting time with useless tests that, as you're hearing from these two surgeons, doesn't really provide them much more information than they really need. It's really going to be based on what they hear in their physical exam that's going to really highlight what the next step should be. And if surgery is potentially an option, or non-operative treatment modalities such as physiotherapy, chiropractic, different types of injections, potentially medication. But it all starts by giving us a call so that we can you will speak directly with me, and we'll simply go through some inclusion and exclusion criteria to see if this is a good fit for you.
1-855-55 Lou, DRLOU, info@paincarecanada.com, through email as well. Lots more of the Dr. Payne Show on the way. Global News Radio, 640 Toronto. 1-855-55 Lou, DRLOU, info@paincarecanada.com. Let's get back into this, Dr. Lou. Kind of ended off with arthritis, right?
Yeah, we're continuing to talk about the knee here, and we've been speaking about arthritis of the knee, and maybe we should define that for our listeners so that people know what that means, what degenerative changes of the knee potentially mean. So, Dr. Bragava, can you give us some med school here?
Any bone that you look at, the end of the bone is coated with a very frictionless surface like Teflon.
Right.
So when you look at the end of a chicken bone, that glistening part, that's the cartilage.
Yeah.
So cartilage on cartilage, the friction of that is better than ice on ice, if you can believe that.
Right.
However, with time, that Teflon starts to wear, and then you start to see some of the underlying bone, and then you don't get that coverage, and it's painful. So that's what arthritis is.
And there's really two types. There's the degenerative type, which is what we're talking about. There's the inflammatory type, like rheumatoid, which we're not talking about. We're talking about the degenerative.
Yeah, so you can get degenerative changes due to autoimmune diseases such as rheumatoid arthritis, or different type of arthritides that happen due to a systemic reason. But we're talking more about the wear and tear. What are some of the reasons that coating, what leads to that? I guess part of it is just being human, that over time we break down. But are there other things that can maybe expedite that process, that natural wear and tear?
So I think certainly injuries can play a role. So people that have had active lifestyles and had injuries, those people certainly may be more at risk to develop arthritis. There may be some hereditary genetic factors that we don't fully understand,
right?
Where it runs in families. Ligament injuries that go untreated or even treated may have an increased risk of it. As we talked about, if you lose a significant portion of your meniscus, then specifically in the knee, that may lead to more arthritis.
How about lifestyle, size, and weight? It's a weight-bearing place, right?
Recently, actually, they did say that weight does have an influence. Now, for years, it said there was no link, but now, as I understand it, there is evidence now that weight can affect arthritis. But the other thing is, Manoj and I see a lot of athletes, and we'll have people come in, and I'll say, well, I've got this problem with my knee, and we're actually not sure, do an MRI, find out that they do have some degeneration and tear. Well, how far do you run? Well, I run 200 kilometers a week.
Well, God forbid. Settle down, Forrest Gump.
So, run, Forrest, run, but not as far. And one of the things there is common sense. So you have to do other things. You go on an elliptical, you do non-impact, you ride the bike, then you run.
Cross-train.
Cross-train is critical. And someone we never tell anyone not to do what they love to do, but we tell them the risk. And it's no different than if you had your car and you had to drive to Montreal every day from here, or drive down to the lakefront every day. Obviously, your car is going to wear out a lot quicker. The one that goes to Montreal every day then comes down here to the lakefront.
And if you ride your car and you have an extra 50 pounds in the trunk,
it's probably not.
Your tires are going to wear out faster.
And now, I guess even some anatomical anomalies that people have. Maybe if they're flat-footed females with the wider pelvis, that can put more pressure on that hinge joint at the knee at different points, right? Is that not a contributing factor?
Sure. Well, as you know, Dr. Lou, your back being out of alignment, other injuries, all inequality in strength, and that's why rehab is so important, where you're trying to equalize the strengths and the symmetry in your body, all very important. So, again, you're good at orthotics and braces and that sort of thing when you find that sort of misalignment or problem. But the key thing, as we talked about earlier, is that mechanical problem in the knee. So if you've got that stone in your shoe, you've got that meniscal tear, you got to get rid of it.
Yeah, and that's simple. Give us a call and see if you qualify for this clinic. And again, you don't need a referral from your family doctor. If you do have one, that's great as well. We will obviously accept referrals from family doctors. But if you're listening, it's hard to get in with your family doctor, or it's just not accessible, give us a call. You will have a discussion with me. You'll leave me a voicemail. I will give you a call back within 24 hours. We'll have a discussion about what's going on. We'll go through some inclusion-exclusion criteria, and then you'll be sent to see a knee specialist. It could also be one of these two gentlemen sitting here. And again, this is all with the intention of really improving outcomes for people suffering from knee pain. And I think it's very important to highlight right now as well that I think the people that could probably benefit the most from this type of program is an acute type of injury, something that's sudden. I'm not saying if you have a chronic knee issue, don't give me a call. Give me a call. But I do think this type of knee clinic, this initiative that we're running is going to be really, really beneficial for that person that it's sudden, they're unsure. Get in, and as we've gone through, you don't have to worry about going through useless testing that's not going to provide any more information. It's going to put a burden on our healthcare system. You're going to be seen and you're going to be treated right away. And the advantage of treating anything in an acute or subacute phase is your outcomes are better anyways, because once you get into the chronic phase, we've gone through this a lot in the show. Chronic pain is a different monster in the sense that now there's a psychological component perhaps that, we don't have good answers towards that type of stuff. So absolutely in the acute phases where you really want to take advantage of this type of program.
I think you pointed out well that the knee initiative will work probably its best for someone with an acute knee injury.
Right.
And I think we'll have the biggest bang for the buck, biggest sort of impact on people's lives if we intervene on those kind of patients early on.
What is acute, Dr. Bargava? Answer the question, please.
I didn't know I was coming to court. Yeah. Acute injury. I would say the definition is something happened to your knee suddenly, violently, perhaps within the last 4 to 6 weeks.
And that's usually a good time frame.
Yeah, usually associated with some swelling right at the time, possibly a popping sensation, which we'll talk about possibly in the next segment as representing an ACL tear.
We will. 1-855-55-Dr. Lou, DRLOU, info@paincarecanada.com. It's the Dr. Payne Show. Lots more coming up right here. Global News Radio, 640 Toronto. 1-855-55-Dr. Lou, DRLOU, info@paincarecanada.com. The knee clinic, it's new. We'll get you in there quick. Just make that phone call, send the email, and get that happening. Right?
Yeah, for sure. So we've talked about arthritis. We've talked about the meniscus. Another very, very important structure in the knee that's often heard is the ACL. And again, I'm going to turn it to the experts that are here with us today to discuss ACLs, what it is, the types of injuries that occur, how it gets treated, etc. So I guess we'll start with you, Dr. Bargava.
So ACL stands for anterior cruciate ligament injury. Most of the times that I see it is people playing soccer, usually women, as Dr. Gordon was mentioning, 6 times more common for an ACL tear to occur in a girl or woman.
Is there a reason for that?
Yeah.
So the reason that we believe it is that the notch, which is in the thigh bone where the ACL sits, is a little tighter, smaller. So it acts like a guillotine sometimes in a violent type injury. So they have the chance of that ligament being torn more. And two of the classic sports, as Manoj said, one is soccer, the other one is ultimate frisbee, because there's that submarining when someone jumps up and you come down and you twist. So it's always a twisting type injury. You've seen it in basketball.
Oh yeah,
it's a common injury in a lot of different sports. We were talking about baseball, basketball. It's one of the most common knee injuries, if not the most common that maybe you gentlemen see.
And usually people may associate with sort of a violent sort of hit to your knee, but most often it's a non-contact injury. So you're on the soccer field, your spike gets caught, and you turn, and that's enough.
And it's that twisting
nobody
motion,
hits you.
right?
No one hits you. Your foot gets planted. So the planted non-contact injury is likely the most likely mechanism for the injuries to occur, whether it be soccer or basketball or whatever.
Where there's a twist in the knee. It's a hinge joint. It's not meant to turn that way, right?
Correct.
Yeah, there are some degrees of freedom in the knee, but not as much in the twisting. And I've been riding a good friend of mine's son. He was playing soccer, went to kick the ball, missed it, kicked the ground, and tore his ACL.
Oh man!
So hate when that happens, but
it happens.
But I'm going to be bugging him about that for years and years and years. And they didn't score either, so it was pretty bad.
What are some of the initial symptoms that? Because I guess not. I mean, obviously, if someone is playing something and they hear a pop, that could be a full tear. But what are some of the things where it's not a full tear of the ACL? What are some symptoms that people should look out for?
So we were talking previously about imaging. So here's a trick: if you have that kind of mechanism of injury, and you feel or hear a pop and have almost immediate swelling, 70% of those people will have an ACL tear. That doesn't need any imaging.
Stupid question, but is it extremely painful or mostly painful?
Well, let's do it to you right now.
Yeah, exactly.
Right.
Is it seriously? Is it not as painful or more painful than it would appear, or is it mainly a visual thing?
I think it varies. Some people can't. Some people have to be carried off the field, and others walk it off. And
didn't Wentz for the Eagles play 2 or 3 more plays with his torn ACL? I think he did.
It's tough.
Yeah.
Well, there's a lot of soccer players out there that have torn ACLs that are playing. One of the structures, the hamstring, that provides a similar function to the ACL. If you've got a good hamstring, it could almost act in the absence of an ACL. Not that I recommend that.
And something that's important, not everyone who tears their ACL has to be operated on.
Right.
And there's another ligament in the knee as well called the PCL, or posterior cruciate ligament. And a great player, one of the top players of all time in the NHL, Stevie Yzerman, played without a ligament, I understand. So for years and years. So you don't have to have it repaired. Most of the time you do. But again, the key with the tear is not only that you see a tear, it's the function that's so important.
Right.
So if you find that you're walking, you can't twist, or you can't turn to catch a bus, or your knee gives out, or buckles, then it's not functioning very well, and you would have to reconstruct that type of knee. And Manoj, maybe you want to talk a little bit about reconstruction of knees.
So, I mean, people who have had an ACL tear and who have done the rehabilitation and still continue to have instability, which is sudden changes in direction, their knee gives out, or it feels like they pop, or anything like that. Those are candidates who would require or should probably undergo ACL reconstruction. One of the benefits potentially of ACL reconstruction is to prevent future problems. So,
right.
But we'll talk about that in a second. The main reason to do it, I think, in the present setting is if you have acute ongoing instability after an ACL tear.
The function, yeah.
So if that's the case, when the ligament is torn, you can't just sew the ends back together again. You have to do what's called a reconstruction. Reconstruction means you have to take a ligament from somewhere else,
right,
and you have to replace the function of the ACL, and then you have to fix it on both sides in some way. So commonly, there's a few different grafts that we use. One is the patella tendon from the front, which is used fairly commonly in pivoting type athletes. Hamstring is another popular option. In older patients, sometimes we use tissue from a dead person, like an allograft.
Right.
That may work. All of them have really good success rates, and you have to individualize the treatment depending on what the patient wants to do in the future.
Mm-hmm. Yeah, I think that's important.
And rehabilitation after is key.
Yeah,
it's a very different. So for a meniscus, usually it's 3 to 6 weeks. For an ACL, it's 7 months.
Yeah,
and the Jerry Rice story. I can't remember if Jerry Rice said he was in San Fran, the 49ers, injured his knee. His doc wanted him to get back really quickly. Rice wanted to get back really quickly. Came back in 4 or 5 months instead of the 7. First play of the game, what happened? Crack. Broke his kneecap. Yeah. So it is 7 months, 6 to 7 months, rehab.
Or longer.
And I think the rehab component is another important thing to highlight here, because I've through the radio show, I've met a lot of different people who, for different areas of the body, but even including the knee, have surgery and they don't do the rehabilitation that they're supposed to be doing after. And it's just not a good idea. You have to get this area of the body stronger again, back to its full mobility, its function, and go about it that way for sure.
1-855-55 Dr. Lou, DRLOU. It's info@paincarecanada.com. Make that appointment. At least give Dr. Lou a call and get it happening. We've got a few more minutes left to go here. The Dr. Payne Show, Global News Radio, 640 Toronto. 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. Talking about the knee clinic. It's new. Get in there, make an appointment. It'll make things go much more quickly.
Absolutely. Yeah. Give us a call. It's very important if you're suffering from any type of knee pain. Let's have a discussion. If you qualify, you will be sent to see a specialist right away. And, prior we were talking, before we went to break, we talked about rehabilitation, which is what's often done post-operatively. But one thing that's very, very important to highlight is how important prehabilitation is, which is when you do different types of active therapies and modalities with a trained professional like a physiotherapist or a chiropractor prior to having surgery. Dr. Gordon, can you highlight the importance of that?
So that is critical. Once you have been injured, I think it's really important right away to put ice on whatever your injury is, to get the swelling down, elevate your leg, and do whatever you think it is important to get that swelling and the injury healing quickly. So we do know that the quicker you address the swelling and the pain, the quicker you'll get back to strengthening and range of motion. Range of motion is very, very important to get back. And sometimes Manoj and I will wait till we get range of motion back before we even operate on somebody, because it's so critical to do that. So getting rid of the swelling, keep up your strength, keep on rehabbing or prehabbing before you potentially have surgery is very important, because we know that if you strengthen and do all that before surgery, you're going to recover much quicker after surgery as well, and your outcomes are better after surgery.
Right. And so this is very, very important to highlight that don't think that if you're going for surgery, it's just the surgery aspect. There's stuff that you should be doing before, immediately following your injury. You're going to have to do stuff after. But this is the beauty of the knee clinic and getting in. You'll be given all of this information. You'll know exactly what to do and how to improve your outcomes, because at the end of the day, if you've been hurt, all you really want is that you're going to get back to normal, or as close to normal as is possible. It's you can't always hope to be 100%, but I think most people that suffer from injuries know that they just don't want it to affect their lives day to day. Dr. Brugava, can you kind of take us through what we've talked about in this show today about the meniscus injuries, arthritis, all the things that people should be aware of when they're dealing with their knee pain?
So I think some of the things that we went through today, the importance of what a locked knee is and how important that is. So if you have an injury to your knee and you can't straighten out your knee, that's a locked knee.
Right. Okay.
Until we prove otherwise.
Yeah.
Sometimes it's spasm, but you have to assume that there is a problem. Don't be like the patient I saw yesterday who comes and sees someone 6 months later.
Right.
If you have an injury and you have immediate swelling and you have this popping sensation, you should be concerned about a ligament tear. Prehab is really important. I just want to go through. In the United States, probably about 20 years ago, at the bottom of a mountain where there's lots of skiing, they thought it was a great idea to start operating on these people right away. So if you tore your ACL on the mountain, they would bring you down. The next day you would have ACL surgery.
Wow.
And what it turned out was all those patients got stiff because the injury incites this sort of inflammation in the knee, and to operate on that knee when it's inflamed led to all these problems with stiffness of the knee.
Whereas doing therapy
where
first
the
will help with
prehab
that.
is so important. So typically we will delay the surgery for an ACL for up to 6 weeks to let someone regain the range of motion, get rid of the swelling, build up the strength, and then do the operation.
Right. Okay. So again, that's very important. Give us a call if you're suffering from knee pain. We've gone through some things. If you have a locked knee, if you've got swelling, if you've got clicking, if this is an acute injury, especially, I think like we said earlier, that this is probably a program best suited to those types of individuals that have something very, very early on going. And the advantage, again, is you're going to get in very quickly to see a specialist who's going to take you through all of this stuff that we've just gone through today and the team surrounding these specialists. And it doesn't end there. There's, again, if you're calling and you need to, if one of our specialists recommends that you need therapy through our provider network anywhere in Ontario, we can recommend good places for that therapy. And so this is a very, very important initiative that I think that we're doing that's really going to help improve the outcomes for people suffering from knee injuries. And thank you very much to these two gentlemen, to Dr. Manoj Brugava and Dr. Rob Gordon, for being here with us today and providing their expertise.
All starts with a phone call as we wrap up for another weekend here. 1-855-55-Dr. Lou, DRLOU, and info@paincarecanada.com. Till next time, the Dr. Payne Show, Global News Radio, 640 Toronto.